Good afternoon, everybody. Thank you for taking time out today for today's webinar, Reducing Risk with Standardized Education in the Emergency Department, featuring B.A Healthcare Group. My name is Tom DeSantis, and I'm from the team at Advanced Practice Strategies. With me today in the driver's seat is Laura Sparkman. She's our VP for Clinical Effectiveness, who works directly with our clients, and especially when we analyze the data. And you'll get a better understanding for what I mean as we go deeper into our discussion. Laura also brings a unique perspective in that prior to APS, she was a clinician who was focused on patient safety at a large health system. Laura, welcome.
Good afternoon, everybody. Thank you.
I'd also like to welcome and introduce our special guest, Al Duke, the Manager of Emergency Medicine and Patient Safety at B.A Healthcare Group. Al brings over 13 years of emergency department experience to B.A. From staff nurse to department manager, he has served in all capacities in the ED, at both urban academic settings to smaller community hospitals. He's a contributor to the development of core competencies in emergency nursing in partnership with the Emergency Nurse Association, and he's been published on this work. He's also presented both locally and nationally on team steps, simulation, and the use of Lean Six Sigma strategies. Welcome, Al, and thanks for sharing your experience with us today.
Thank you, Tom. I'm glad to be here.
Before we get started, when we were planning today's discussion, we thought of the questions you may have, knowing that some of you are current clients using GNOSIS for OB, so you already have an understanding of what we bring to the table, while others are completely unfamiliar with the platform. So for you, this might be like GNOSIS 101. Also, some of you are from risk, some are from the ED, and some are from nurse leadership. But regardless, we're all focused on doing what's best for the patient, so I'm sure what we share today is going to resonate with all of you. First, we're going to cover what is GNOSIS. We'll talk about personalized learning. How is GNOSIS different? We'll show how data has been a real game changer in the space. What is the impact of GNOSIS? We'll highlight some of our client success. Why emergency medicine? We'll share some national data, and Al will share data as well, on risk in ED. And then how can a client reduce risk with GNOSIS for EM? We're going to ask Al to walk us through the B.A experience. Everyone's actually defaulted to mute right now, but if there are any other questions, just please type them in either the chat box or the question box. You can find it on your dashboard. And either during the presentation or afterwards, we'll address them. And we planned about 30 minutes for today. We have no problem at all answering these questions or specifically after the presentation as long as you need to be on the call. Laura, at this point, I'd like you to start us off. Can you give us a brief overview of who we are and what we do over at APS?
Absolutely. And as Tom said, I'm going to jump right into this. And obviously, it's going to be real important. We want to make sure that everybody is hearing from Al as soon as we can get to him, because he's a wealth of knowledge and experience and an emergency medicine expert. But so what is GNOSIS? GNOSIS is one of the solutions offered by APS. We have two patient safety platforms designed to help health systems retain clinicians, reduce risk, and improve outcomes. Our programs are focused on addressing real issues that clinical and health system leaders are managing daily, and that is bringing the right people into the systems, make sure that they're matched to the best care setting for their success, and that patients are getting the expected and the good quality and clinical outcomes that we want for our patients. Also, reduced orientation times to have active and safe care team members, which all leads to reduced turnover and satisfaction from your associates. And then continuing on that, the continuum of our solutions is the GNOSIS component, which is education and patient safety risk reduction. So it's really delivering and supporting ongoing career-long learning. So you may be asking yourself, how does GNOSIS work? And what's really unique about GNOSIS is this is assessment-based education. And what we're not going to do today really is a demo, but rather we want to focus on the value of GNOSIS. So as I had just said, GNOSIS starts with an assessment that then generates an individualized and prioritized learning path. The assessment data provides insight into proficiency, variation among the team in terms of knowledge and judgment, and the opportunity to support individuals and the team in proven areas that potentially represent risk to the patient and to the organization. So imagine you have a clinical team that is not performing to their highest potential. You, as a clinical leader, you have a sense about that something's not quite right, and you want to support your team for improvement. But imagine that you have data that can support that thinking and reinform and point you in the right direction to make improvements. One of the things I say from a patient safety leader perspective is you can't improve what you don't measure, and this is one of the key value points that GNOSIS delivers is targeted, focused analytics that drive improvement.
Yeah, and Laura, that brings us to the next slide. You know, we talk about the data and we talk about the analytics. Can you speak to this? This is basically showing improvement in learning. Can you talk to that?
Absolutely. So this is a great example of actual, it's de-identified data, but this is a multi-hospital system. You'll notice the orange boxes represent hospitals, but this is assessment and change over time. So assessment 1 gives you your baseline data, which you see that black triangle represents that system's average. The blue lines represent the APS national database, which we have a very robust and large database, over 400 healthcare systems, over 15,000 nurses, over 5,000 providers in our database. But again, one of the largest databases in the country to measure improvement in knowledge and judgment.
We actually just yesterday we surpassed 60,000 assessments. That's
Thank
kind of a
you.
milestone.
Well, excellent.
In terms
See
of
what happens when you go on. Yeah, when you go out on vacation for 1 week, what happens? We just keep growing and growing, which is amazing. But again, it speaks to the value of the database and the richness of the database, and using that as thresholds and benchmarks which to measure improvement over time. And again, this is one example. We see it time and time again with multiple clients improving from one assessment to the next. We have some very specific client examples of the impact of GNOSIS. And this first graphic to the left, which large statewide health group, this is B.A actually, so you'll hear more about this from Al shortly. But actually reduced, it says risk by 50%, but also reduced the total number of claims and the cost of claims, which is significant in a very litigious healthcare environment that we are in now, and especially even in California. And to the right of that, a large regional children's hospital that has a very large OB service line actually decreased massive transfusion protocols, or as I like to call codes, which has a real patient safety impact, a real clinical impact to the patient. So GNOSIS became part of the total protocol and education and training for their staff on obstetric hemorrhage. So they reduced on the clinical outcome side the number of codes, and also on the financial side the total number of resources, blood products, and supply use, which is significant, especially in today's healthcare market. You know, what we'd like, Al, is for you to take a little bit of time and kind of introduce B.A, and then we'll keep moving forward. So, Al?
Great. Thanks, Laura. Thank you, Tom. Thank you for having me on, and good morning or good afternoon, depending on which part of the country you guys are in. Hopefully your weather is nice as well as mine. So what I want to do is just take a minute or two to introduce B.A so that you can kind of understand the framework from which we as an organization are coming from. So B.A Healthcare Group consists of 2 insurance entities, B.A Risk Management Authority, which is a joint powers authority in the state of California and a risk pool, and our Health Pro organization, which is the Health Providers Insurance Reciprocal. And both of those 2 entities make up B.A Healthcare Group. So we have the not-for-profit side, and then we have a for-profit side. Basically, B.A came together, or actually I should say, about 14 hospitals came together in 1979 at the height of the insurance premium increase market, and decided that they would take on the opportunity to fund and pool their own monies to offset claims and risk management areas. So they were granted the Joint Powers Authority about a year later in 1980. And then later on in the 90s, Health Pro came into place when we started seeing organizations, particularly the medical group side of things, where we would insure the hospital, but not necessarily the physicians group, and they saw and wanted to take advantages of the opportunities that B.A offered. So at that point, the board of directors decided it would be a great idea to create an opportunity for medical groups to join. And then as we've progressed, we've also had the opportunity for additional hospitals to join on the for-profit side. So my particular role is in the emergency department patient safety side. And then within B.A, we have 3 branches. We have the underwriting side, which basically are the ones that quote the insurance premiums and know the numbers and all that stuff. We have a claim side that handles what happens when there is an issue. And what we do in the risk management side, which is the division that I'm in, is our job is to try to mitigate that risk, a lot similar to what your risk managers in your facilities, or even those of you that are directors or managers in your department, do the same thing. And we have a fairly tough job being managers and directors in the facility side, because you're dealing with all kinds of pressures, and B.A has taken a stance in the risk management department to help try to offset some of those challenges and with our organizations, and we have teamed up with APS to help do some of that.
Yeah, I was just going to jump in and say, yeah, we've been working with B.A for about 3 years now, and again, a very large entity in California, but has been very successful in launching the OB platform and seeing clinical results. And so I think it clearly led to the expansion of the program into ED. And one of the things that we hear from clients often is, they want to know, well, why did you move into the ED area? And again, ED represents, from a national perspective, a high claims, high hazard area, kind of under the umbrella of patient safety risk. There's one particular study from the AMA that cites 50% of emergency physicians of all ages reported experiencing at least one claim, and emergency medicine ranks 5th in liability claims frequency. So what's interesting to me, again, from a patient safety perspective and a national scope, and again, one of my personal observations, being in this space for many years, is emergency medicine has nationally not really come together or had that significant burning platform like OB did historically, but that is really starting to change. And Al, some of the things that I've also observed is there hasn't been a real push nationally to reduce the variation in how providers, ancillary providers, nursing in the emergency room are educated, in terms of skill set, knowledge, judgment, as in other clinical areas. But I think we're kind of on a change in time around that, and I just kind of like to get your experience and insight into that.
Laura, I thought it would be a good time. I want to do a quick poll completely related to that. We know how prevalent risk education is in the OB. How about with the ED? Does your organization have a standardized education in the department? In other words, is it something you offer to all your clinicians on a standard basis? Give everyone just a couple of seconds, and then we'll close it out.
Yeah, that's a great question, and it'll be interesting to see what the results yield on that.
I'll share them in a bit. Why don't you go ahead?
Perfect. Yeah, no, so I was going to say, yeah, while you're kind of pulling all those results together, we have a good number of people and participants on the call today, so that'll be really interesting. Al, why don't you go ahead and, take some time here and kind of explain, why ED education is important to B.A.
Sure, I'd love to. So as mentioned, in frequency in the nation, the EDU ranks number 5 in frequency, but in our organization, actually, the emergency medicine claim frequency is actually number 1. We see 31% of our claims that come through end up originating in the emergency department, which is a very significant number. And when you talk about the number of entities that have emergency departments and that we insure, which right now we're over 80 emergency entities, that's either hospitals or physicians groups, a majority of those being EDs themselves, that's a significant number. But then you talk about 15 additional emergency groups that are not practicing in hospitals that we cover. So we have a fairly large, wide scope. And the real challenge becomes when it comes to a claim, as many of you may know, it's not just the emergency department that's brought into the claim, it's the physicians themselves that are brought into the claim as well, and vice versa. If it was a physician-related issue, it's still the hospital that's brought into the claims. And so nationally, we're seeing about a $40,000 cost average per claim. And what our organization is seeing is about $71,344 in cost per average claim. That not only includes any indemnity or amount that we have to pay out, but that also includes the cost of trying the issue or getting to a settlement state. But also with the emergency department, the other number that's actually additional that we look at is the severity of the claim. And really, the emergency department accounts for 25% of all costs associated with claims. So for us, that's a pretty significant amount. And on average, we average somewhere about 1,000 claims filed per year. So you can see where that number can get very expensive very quickly. So our objective is to try to move our organizations into a proactive approach, and we've been doing that for quite a number of years now. We're going on our 5th year with the ED, working on very specific initiatives on patient safety to try to be very proactive to prevent some of these claims, and I'll talk a little bit more about that towards the end of the presentation.
Thanks, Al. Actually, I'm going to share the results of the poll real quickly. So you can just see 9% have said yes, they have some kind of standardized education. And here on the screen we have some information from ASAP, American College of Emergency Physicians, which is a good umbrella group for these topics. I won't read the quote to you, but basically in one of their publications, they recommend education to help deal with this. Laura, if you could just look over there at their 10 areas of vulnerability. I'm looking at like 3 right away that are jumping up that we address right in GNOSIS for EM.
Absolutely, yeah. I mean, clearly, knowledge deficit, failure to diagnose, failure to communicate, failure to order and interpret diagnostic studies. I mean, actually, you could group several of these top 10 into 3 major buckets that, trying to get to a differential diagnosis, is the yeoman piece of work for the ED team, and but these 10 areas are what drives claims, not just and patient harm, but the programs that we offer address those areas.
Exactly, and next slide, Al. This is something that that Beta looks at pretty deeply.
Oh yeah, for sure. That's one area. So we try to get to what is causing these claims to occur, and then what can we do to help alleviate some of these claims in the future. And so these are the top 5 claims, both in frequency and severity, of issues that we see within our organization over the last 5 years, from 2010 to 2015. And of course, surgery and improper performance, well, that's really skill-oriented. But leading into that are 2 other areas that are significant for us. One is improper treatment, and that we've been finding stems really from failure to diagnose the proper treatment. And so you can see that we can have a cascading effect where maybe the initial claim was not filed because there was a failure to diagnose, but when you dig down a little deeper into the taxonomy piece of it, you'll find that usually starting with the diagnostic process, either in the triage area, which starts what we look at as cognitive bias in that process, where it starts with, oh, this patient is having chest pain. Okay, so now the physician is handed an EKG that either is or isn't an acute MI, and then that could lead us down the improper pathway for treatment, which could also lead to improper performance of those particular procedures. So we kind of drill down into these, and some of these categories merge, but for us, we have some pretty significant dollar amounts coming out of failure to diagnose and improper treatment, which are the 2 that really go hand in hand with each other. And of course, one of the things Dr. Coskery released back in 2013, an article in JAMA that talks a lot about cognitive biases and how do we get that out of that particular arena and get away from developing cognitive biases. And so those are some areas that we really look at. So Beta has structured a platform in which we have a 2-tiered patient safety incentive. our first tier, which is our online standardized education platform, which now we have moved to the GNOSIS platform, which we do high-risk chest pain in the emergency department. But we originally started with the Sullivan Group, and with the Sullivan Group, we found that there was good standardized learning education, but we weren't exactly sure how that education was being utilized or whether it was actually being very effective. So when we started looking at alternatives to figure out what was the best way to move and kind of get the best program available for our members, we wanted to look at some of those things, particularly anything that would deal with cognitive bias and trying to mitigate some of that cognitive bias that we were seeing in some of our claims that leads to some of those significant misdiagnosis and improper treatment. So of course, last year in 2015, we had 32 member and insured organizations meet that tier 1 category, which is about 42% of our organizations. And so at the basically end of 2015, we had about 374 nurses and providers that have completed the GNOSIS pathway. And I think we are actually expanding beyond that now as we're heading into our next policy year. And then we had 6 member organizations that met the tier 2 criteria. So above and beyond the standardized education and online platform that we use with GNOSIS, we offer other areas that can be focused on. And we had some common areas that we try to focus people on this year. Safer handoff is very big in the literature, talking about making an effective and safe handoff. Sepsis, there's a lot of movement this last year in sepsis because of the CMS changes in the guidelines. We wanted to make sure that organizations were up to speed. And then, of course, the challenges of creating a triage system that's not only standardized and can be reproduced, but will actually give you positive outcomes and not over or under triage your patients. And those are some of the basic areas that we have developed and gone. So one of the things that we were looking at as we came along in the platform is we were looking at how do we get education that really meets the needs of everybody, not just the low performers and not just the high performers, but how do we encompass everybody so somebody comes out of the platform and goes, okay, I learned something today. And what we were struggling with as an organization is with the platforms that we were using in the past, we had no real way of knowing was there any improvement in the process. Did the individual learners get any benefit from it? We just knew that they took it and they had completed it. So with GNOSIS, we actually add another layer that's actually even more powerful, as Laura sort of showed you earlier in the presentation, that we can look at individuals or organizations and see, are we seeing the proficiency levels improving? And so this particular slide will show one of our providers that had taken this particular module, and you can see some of the areas which are really nice because they break them down into so many different categories. And you can see this happens to be a knowledge assessment score that shows you their general knowledge. And so looking at these categories, we can see where they rank not only within the beta organizations, but we can also see where they actually rank as a national average for a provider in that particular category. And then the benefits of doing this is that we can now have tailored learning to the individual, not just blanket education for everybody and hope that they grasp some of it. And we look at a year-to-year, we've been starting to look at a year-to-year analysis on team proficiency. Particularly, we don't, as an organization, we don't look at the individual. This is a great opportunity for managers and educators to look at their individual organization and their individuals within the organization and help them increase their proficiency where they may be struggling. For us as a general organization, we like to see where our organizations and our members and insureds rank as compared to other beta organizations and compared to the national average, and it gives us an opportunity to help also steer them along. And of course, the question that I often get as someone trying to get an organization to jump on board to our patient safety initiative is, well, you know, we're a really high performing organization, and we have several very high performing organizations within our members and insureds. But even within, and this is a great slide that demonstrates that, even within very high achieving and very high performing organizations, we still see room for improvement. I mean, as you can see, this is actually someone who scored in the top 100th percentile. He had an 87.5%, which is in the top quartile of all organizations. And yet down where it says bias in medicine, recognition of multiple forms of bias, they didn't do quite as well. So that's an area that even within an organization with top achievers, they can start thinking, okay, well, now as an organization, that's one area that we can look at and work on, is that bias, and how can we help improve the bias piece of it and help educate people to their recognition of bias, because that's one of the challenges that we have on a daily basis when it comes to bias.
You know, Al, this is Laura. Just, I'm sorry, Tom, if you could just go back one slide just for a moment. I mean, to compare those two stories of those two individual providers, the low-scoring provider versus, you know, a higher-scoring provider, to your point, the low-scoring provider is going to have a very different learning path because, again, it's assessment-based education, and then what comes out of this is education in these 6 practice areas, right? So this particular provider is going to have a much, you know, more content on what they need and what they need only. And then if you go to the next one, the high-scoring provider, this individual is going to have a much smaller and condensed learning path and only going to be getting what they need. And so that's the value to the clinician, which we're going to get to later, which is, you know, it's efficient and it's effective, and it's the provider and care team satisfier because they're only getting education they need. So I just wanted to kind of underscore some of those points.
Oh, that's exactly right, Laura. That's exactly right. So what this actually slide wanted to show you is, from an organizational standpoint, this is actually our loss frequency occurrence dating back to 2010 through 2015. So if you look to the left of the slide, you see that 12.21. That was when we started developing ED initiatives and trying to create a patient safety initiative to our member organizations. So what this graph is showing you is that in 2010, there was actually 12.21 claims per 100,000 ED visits. Now, if you are an organization that sees 100,000, that means you're going to see roughly 12 claims per year coming out of your ED. Now, imagine 12 claims coming through in 1 year. That's a significant amount. And like I said, Beta as an organization sees roughly 1,000 claims a year. So you can see, now as you see the trend line going down, the numbers are getting smaller, and that's sort of a natural progression over time, particularly with some of the legislation here in California. And there's other factors that cause that to occur. But what you'll notice on the far right side is in 2015, you see a 0.86 per 100,000 claims. Now, the real challenge that we have in the claims side of things is that really it takes about 3 years from the filing of a claim to the closing of a claim on average. So really we're starting to look at 2012 as what we call a closed year, and that means we've seen about 7.91 claims per 100,000. So we've seen a drop in claims, and for us that is a big number. The numbers on the right, those numbers will start to roll up, and we'll finally have a real number that we can look at as a comparison data sometime about the middle of this year. But what this graph shows is that for us in California, just the general content and idea of patient safety is starting to lower claims, and we're starting to get penetration into the ED realm. I remember starting my very first job as an ED manager was in 2008, and on my radar, I didn't even think about lawsuits and claims. I was more worried about regulatory issues. But now we're starting to see that risk and claim go hand in hand. And we're also starting to see regulators taking stances in areas where we're frequently seeing lawsuits before, and now we're starting to see regulators take interest in those particular areas as well. One of the significant things that comes up about this is what are the benefits for my organization? As we've seen, my organization is really trying to take a very strong proactive approach to decreasing claims, and in the end, that saves our members on premiums for next year, and then it saves future members for premiums. But what are some of the selling points that I've used to get my organization members on board and want to actually do these? And I actually have found 4 key things that I have found, particularly from a manager and an educator standpoint, that have been very helpful that I have seen as I've been doing this. And one is, as mentioned before, and this slide is a great representation of that, is time it takes to complete education. So of course, one very beneficial component that we have found from GNOSIS, particularly physicians have said this multiple times to me, is, you know, I want to learn what I need to know, but all that other stuff, I don't need it and I don't want it. And so what we've been finding, as you can see on this slide, is it really does save times, particularly on the provider side. Based on the assessment model, by doing the assessment, it allows them to cut down on the learning pathway times that they have to go through to get completion. And you'll see it as well on the nursing side. We see the same thing. What does that mean for managers? Well, that means decreased costs, because as managers, we all know that every time we do, A, you have to purchase the learning platform, but B, you also have to pay staff to actually do this. And so that has shown to decrease the amount of time that somebody has to sit in a standardized platform that other organizations have put out there and we have moved away from. For risk managers, one of the benefits to doing this as a risk manager is you are now creating a standardized patient safety platform that you, as an organization, can roll out, and you can reap the benefits from the patient safety side of those things. And of course, our goal is to reduce the claims that we see.
Laura and Al, I think you could probably talk, you know, a lot more than just a half an hour on this, clearly. And we did actually get a couple of questions throughout. Folks wanted to know, and Al, you mentioned Sullivan Group, which was a prior vendor. What do we cover in the EM module? Like what we say high-risk areas, what are they? Laura, I know you can probably do an overview of this. And
Sure.
Dr. Binder's on the call as well, so we could ask him as well for some insight.
Oh, perfect. Perfect. So I'll just do a kind of a quick introduction of what we have, and then we'll ask Dr. Binder, who is our medical director for and content lead for all the emergency medicine programs, and he's currently, just to give a little introduction, an associate professor of emergency medicine at Brown University. So a pure expert and his finger on the pulse of what's happening here. But we introduced GNOSIS for EM, and our first products specifically are focused on high-risk abdominal pain in the emergency department, high-risk chest pain in the emergency department, and then communication in the emergency department, really focused on you know, patient safety and risk mitigation. And we know that what is coming soon, based on feedback from our clients and kind of, you know, the demand around this, is nurse triage in the emergency room, and then pediatric fever without source and stroke. So Dr. Binder, I'm wondering if you could just maybe give a little insight into why was it important to develop the high-risk chest pain, specifically related to diagnosing chest pain?
Sure. High-risk chest pain is really kind of a broad concept. Patients, about 5 to 6% of all patients in the United States present to the emergency department with chest pain. They don't come with a you know, stamp on their forehead saying, you know, I'm having an MI, or I'm having, you know, unstable angina, or, you know, I've got indigestion. It's you know, tough to differentiate. So our course looks at really an array of really, you know, some of the more important diagnoses within chest pain that cause chest pain, and including ACS, acute coronary syndrome, pulmonary embolism, which can, you know, present somewhat like ACS, certainly aortic dissection, you know, pericardial tamponade, cardiac tamponade, pneumothoraces, and esophageal perforations also are there. We also include gastric volvulus. And basically, we try and look at both the epidemiology of the disease, kind of clinical presentation, pathophysiology of the diseases, and just as we, you know, progress forward, so that you know, physicians and nurses too can, you know, help differentiate and kind of make, you know, very, better choices in terms of diagnostics, so that there is no diagnostic delay, because that really is, as has been pointed out before, that's really one of the leaders in causing, leading a risk, and that's the best way to mitigate risk, is just to, decrease any delays. So that's
Excellent.
what the chest pain course is. The abdominal course goes into, another about 16 different disease entities as well, and we can talk about that. Things that are obviously very important, certainly GU, genitourinary pathology, both females and men. We also extended up into the abdominal cavity and looking at both vascular catastrophes and other disease entities that might mask themselves as a catastrophe and might not be. So we once again will discuss both clinical presentation, epidemiology, pathophysiology, clinical presentation, management, and really also in all these courses we really take a long, hard look at pitfalls, because I think that's really what everyone really becomes very interested in.
And then again, in communication, we don't have to go too deep into that. Again, it's everybody, just even in this visual, everybody is probably very familiar with the Swiss cheese model of harm that actually reaches the patient. And many times we're kind of lucky in healthcare that it doesn't, but you can use those the components in that program specifically address it. One other question I do have for you, Bill: why are we developing a course on pediatric fever?
Fever in a pediatric patient, especially in the young kids, is anathema to many physicians. A lot of physicians, kind of over time, especially in non-children's hospital settings, aren't really necessarily up on the latest, and you just can't really know everything. And on top of which, once again, you don't really want a catastrophic event, and kids, when they go bad, that's a tough thing to handle. So what we discuss in Fever Without a Source is really kind of who is at risk, why they're at risk, really what the changes have happened in the last 20 years during the vaccine era, and the conjugate vaccine era, and also some of the concerns in the increasing population of kids that are either unvaccinated or immunocompromised for various reasons. And we look at, again, both epidemiology, which is very important, but a lot of the important kind of factors that lead into a difficult diagnosis and and something that you'd want to end up kind of taking a harder look at, and who do you culture, who do you
Right.
get blood work on, and lumbar puncture, et cetera. This has become a very important topic. It's it's a wonderful module, and written by a number of really basically people who write the textbook in Rosen textbook are involved in this course.
That's great. And again, I mean, the national data, just one other point on this, even just reading a report from AHRQ, is that the pediatric visits are increasing across the country. So that's, having that expertise in pediatrics where, it's not, is another factor. So thank you, Bill.
Al, this one might be for you, and I know, Laura, you live with this day in and day out, but how did you gain leadership buy-in? Al, you touched upon it a bit, but what do you do, not just at the physician level, but on the leadership level?
One of the things that's been very beneficial for us is the help that we've gotten just from a national push to improve patient safety initiatives throughout healthcare organizations. And so I think more organizations are becoming more aware of patient safety things that they need to do. And so one of the things that's been beneficial for us is we not only take a look at the individual organizations, but our organizations as a whole, and we try to keep current with what's really available and out there. And like I said, in our organizations, with the 80 plus organizations with EDs that we have, or physicians groups, we have varying sizes, and some organizations don't have the ability to pay for products such as this, which we provide for them. So we give them the opportunity to get a cutting edge product getting cutting edge education, keeping current on things. And then the other area that we sell a lot that I think organizations are really starting to really enjoy is the fact that they're starting to get a return on investment. And education return on investment is one of those difficult things to calculate, not impossible, but difficult things to calculate. But being able to see your organization progress over time and move from that bottom left corner to that upper right corner has been very gratifying for organizations, and they've seen that change occur, and they start to see how that improves not only their patient outcomes, and our hope is decreased claims, but also increases patient satisfaction, and their HCAHPS scores go up. So it really all ties in together: patient safety, risk mitigation, and customer service, things that are starting to really get more predominant from the regulatory side.
Al, thank you so much for participating today and sharing the beta story. For the participants, we have about 99% of you still on the call, so I wanted to thank you for taking time as well. Again, Al, Laura, thank you very much, and take care, everyone.